E agora seguimos com o nosso primeiro palestrante internacional do dia, diretamente do Reino Unido, Tom Ince. Tom é diretor do COFINC e professor na Universidade Heriot Watt de Edimburgo e também da Universidade de Dubai. Ao longo de 30 anos de carreira, atuou em cargos de liderança em organizações educacionais e empresariais, sempre unindo design e pensamento sistêmico para impulsionar a inovação e a transformação. Nos últimos anos, tem se dedicado a aplicar essas metodologias no setor de saúde, ajudando a gerar mudanças estruturais e significativas nos sistemas do cuidado no Reino Unido. Welcome, Tom Ince. It's an honor to have you with us at Coniges 2025.
Hello, everybody. It's a real pleasure to be able to join you. I am joining you from Scotland. I'm based in the UK. I'm based in the city of Glasgow. And I've been invited to speak to your Congress on the subject of facilitating collaborative system shift. So my background is in design. I will explain where I have my ideas from and the work I do in healthcare. And so I will be kind of giving you an explanation of my particular perspective on healthcare and healthcare innovation. So my name is Tom Ince. I work through my consultancy, which is called COFINC, which is based in Glasgow, but I also work as a visiting professor at one of the Scottish universities, that's Heriot Watt University, which has campuses in Edinburgh and Dubai. Okay, so let me just explain a little bit about me and my work. My background is in design and innovation, so I'm not a healthcare professional, but a huge amount of my work is in healthcare. And in that work, I always describe myself as a facilitator. So I'm a design and systems coach, trainer, and facilitator. And my work in healthcare fits into three domains. I do an awful lot of work with teams in healthcare who are interested in quality improvement. That's in effect the innovation paradigm that exists in healthcare. And over the last 5 years, I've done a lot of work bringing design approaches into the quality improvement toolbox. And a lot of that work has been with different health boards and trusts in the UK and in other parts of Europe. But over the last 3 or 4 years, that work has moved and has become much more embracing of systems thinking as well. And again, I'll explain this as I go through my presentation. So a lot of my work now is about design approaches in health, but it's also about how do we take a systems approach. And as part of this work, a lot of my work is with healthcare organizations, with hospitals and with trusts and healthcare professionals. But I also do a lot of work with health tech companies. And there are lots of small companies, medium-sized companies that are innovating, particularly in the digital space, bringing new ideas into healthcare. So I work with one of the UK organizations, which is called Innovate UK, supporting small and medium-sized companies as they bring their innovations into the healthcare system. So it's a really interesting area of work. Okay, so as I said, my background is in design. I've worked in many different universities, many different design schools over the last 25 years. And I've always been extremely interested in the way designers think and the way design adds value to problem solving. Now, there's all sorts of different types of designer out there. I'm originally trained as an engineering product designer, so quite a technical designer, but also with the kind of visual side of industrial design. But I've worked with many other designers who come from other design disciplines, architects, service designers, graphic designers, and so on. So the interesting thing about designers is they have a particular approach to problem solving. If we kind of distill it down, everybody has a kind of slightly different view on how they add value. But for me, there are kind of 6 things that design brings to problem solving. Designers are really good at zooming in and out of problems. They connect what I call the macro to the micro. So a really good architect can design the room in the house. They can design your furniture. They can design your house. They can design the street your house sits in. They can design the urban environment that the street sits in. So they're always zooming in and out in their thinking. They are really focused on users. So designers create solutions driven by understanding of stakeholder needs and journeys. So they always put the user at the center of their problem solving. They're always designing into the future. So they are always kind of thinking into future scenarios, because when you design something, it doesn't exist yet. You're always designing for 6 months' time or 12 months' time. They have designers translate ideas into tangible prototypes and solutions for testing. Um, Designers enable teams to confidently work creatively and iteratively. So it's an awful lot about design is about creativity and thinking slightly outside the box. And one of the other key things that designers do is they unpack complexity using tools to map and visualize information. So most designers come along with a kind of quite considerable toolbox of methods and approaches for framing problems and solving problems. So there's a really interesting skill set that comes from design. And in my work, I have, over the last 5 years, been integrating those approaches into the quality improvement paradigm that exists within healthcare. So I've worked with one or two of the key NHS, National Health Service trusts in Scotland, building new quality improvement programs, which build on all of the key skills that come in conventional healthcare quality improvement, but bring in a whole suite of different methods and approaches from design. And the design methodologies really do fit with healthcare. In healthcare, we want to put the patient at the center. So all of those user based approaches that come from design work extremely well in healthcare. Healthcare needs to be creative. It needs to think what else is like this all the time. It needs to have empathy with its end users. And so the design approaches can really add value to what is a quality improvement toolbox, which is quite often based on quite kind of technical considerations of innovation. So in this work, I have done all sorts of different types of activity. One of the most interesting things I did was working with NHS Tayside, which is one of the trusts in Scotland. We created a cookbook of methods, which I kind of describe as fusion thinking. I'm not sure if you're familiar with the term fusion cooking, but fusion cooking is where you do a lot of it in Brazil. I know because I've been to Brazil, but where you bring different cooking traditions from different countries, different regions together, and you mix and match them to create new approaches to recipes and meal preparation. And we call that fusion cooking in the UK. But fusion thinking is where we bring together different paradigms of thinking from different approaches. So this design training for QI teams is really bringing the design and the quality improvement together. And I will provide you with a kind of reference to a paper that I wrote about this with an ear, nose and throat consultant in Scotland for the Design Management Review. It's called Designing Realistic Healthcare Improvement. Okay, so design can bring an awful lot into healthcare. Interestingly, however, if we look at the challenges that healthcare faces, and as a group, as a Congress, I'm sure there's so much discussion that's been going on over these 2 days about the healthcare challenges that face the system. We have policymakers all over the world talking about the fact that healthcare really is in need of a kind of massive change in terms of innovation. In the UK, there's been all sorts of different public reports. A very significant one was in September last year. It was Lord Darzi. He did a review of the National Health Service in England, and he made a whole series of recommendations. He said it's kind of, if we carry on the existing track, it will be broken very soon. We need to re-engage staff, empower patients, expand local care, increase productivity, bring in technology, reform the way we do things. In Scotland, we have John Swinney, who's the lead politician. In January this year, he talked about the need for a fundamental shift in how health and care services work together as a system. He calls for breaking down silos. So in healthcare, there's this kind of massive realization that really to improve, you've got to begin to think in much more of a systems way than perhaps the healthcare system's been doing to date. I had a little peep into what was going on in Brazil. So you've got all sorts of different national plans for health. I know healthcare delivery is quite different to how it's delivered in the UK. You've got a kind of public health system and a kind of an insurance-based system as well. But interestingly, I had a kind of trawl through the Brazilian perspective, and these were the kind of five things that came out. There's a kind of a desire for better integrated system, expanded access, equity, and quality of care. There's a need to kind of integrate new digital advances and data into the healthcare system in Brazil. There's much more focus that needs to be put into prevention through public health, and the system needs to be resilient. Interestingly, those five things that you're doing in Brazil are exactly the same things that Lord Darzi's talking about and John Swinney's talking about in the UK. So there is a kind of almost a kind of global universality to the challenges that face healthcare. Okay, so I've obviously talked about fusion thinking and bringing design into the healthcare paradigm of innovation. But the other mode of thinking that we need to fold in to solve these kind of more systemic challenges is systems thinking. So again, over the last couple of years, I've been working very closely with health boards and trusts to think about how can we kind of get more of a systemic view that's into what we're doing. So systems thinking is an absolutely fascinating set of disciplines to explore. There's all sorts of different models that come with systems thinking. There's the kind of technical systems engineering all the way through to softer side of systems thinking. Whenever I think about systems thinking, I always kind of carry around the mental analogy of spider's web. So this is a spider's web in this in this kind of image. We're all familiar with spiders' webs. So spiders' webs, kind of in a sense, it might seem very strange, but to me, they kind of represent what something like a very complex system like healthcare actually looks like. In our spiders' webs, we've got all of these different strands in it. They represent perhaps the different pathways in our healthcare system. And we've all been in front of a spider's web. You know that if you poke it with a stick or with a pencil or with your finger, if you kind of press one of those strands, the whole spider's web distorts. And if you poke it too hard, the actual strands break. But when they break, the spider's web kind of reforms itself in a slightly different shape. So that's in a sense the spider's web. But in our healthcare systems or any complex system we work in, there's a similar thing going on. If we decide to kind of improve it or change it, we're effectively kind of poking it in one particular place. But in order to kind of do that in a kind of very strategic way, we really have to understand what the implications are for the rest of the system. So if we kind of going to confront and deal with those systems challenges that healthcare faces, we do need to kind of take much more of a systems view of what's going on. And in healthcare, we tend to kind of think in little pockets and silos. Okay, so let's just kind of think about how does this play out. In the healthcare improvement work I'm familiar with, we kind of very often make an improvement or a redesign or an innovation that doesn't have this awareness of what the system looks like. So I think that probably if we look at how quality improvement works in healthcare, perhaps about 90% or 95% of all the improvements that are made with the best intention in mind, but are probably made without a really good understanding of the rest of the system. So they're what I call level zero improvements. They will have an impact. They'll have a direct impact on the system which is being changed, or the part of the system, the silo, but they won't necessarily have as much impact as they would have if the people who were kind of enacting that change had a good systems view of what the system looked like. So in improvement, in innovation in healthcare, we really do need to push up what I've called these kind of levels of innovation. We need to move away from making improvements which have poor system understanding to improvements that have a good system understanding. And ideally, we need to kind of think in a systemic way. We need to think about what does our system look like as a whole, and what are the 5 or 6 innovations or improvements we need to make to really drive system change. we can never really completely reinvent the system. You can't close a healthcare system down on a Friday evening and then restart it on a Monday according to a kind of completely different design. That's like redesigning an aeroplane whilst it's still flying. But we can, if we kind of think systemically, be much more strategic in how we kind of think about our changes. So we can move to kind of a level two system shift if we kind of take a systems view. Okay, so there's a little bit of background on design thinking and systems thinking. Interestingly, if we go into systems thinking literature, there are many, many different approaches that we can kind of deploy. There are many ways of seeing the system. So how do we kind of see this, the cobweb? There are many ways of kind of mapping what does a system look like and using these in our kind of systems thinking within healthcare. In the work I do, my background's in design. I've always been extremely interested in how design helps us visualize things that are complex. And at the core of all the work I do is a kind of methodology, which I've evolved over the last 3 or 4 years, working with a whole range of different healthcare professionals, which is based on thinking about a healthcare system and using some principles of visualization that come from visualizing other complex things like transport maps. So I'm a little bit of a geek. I'm fascinated by transport maps. Whenever I go to a new city or a new place in the world, the rest of my family is wanting to go sightseeing. I just want to see the local transport map and kind of try and work out how does this place actually work. So in this slide, I've got an image of the London Underground. You might have been to London. It's a very complex transport system. And it's made up of all sorts of different metro lines or underground lines. Interestingly, the map in the bottom right-hand corner, it was designed by this designer in the top left called Harry Beck in the 1930s. He took a very complex map of the underground system, which was drawn geographically, and he created this abstracted map, which has kind of been built upon progressively over the last almost 100 years by different designers as the map has expanded. And this map, in a way, I think really does look like, in some ways, what a healthcare system looks like. In our London Underground map, we've got lots of different lines. We've got the Victoria line in London. We have the Piccadilly line. These are like the different pathways that we have in a healthcare system: the cardiology line, the diabetes line, the urology line, the maternity line. If you're a patient, you come in and into the system. You usually come in from the suburbs. So in London, we call that zone 9. And you come into the centre, which is zone 0. And you might come on any particular line. You kind of cross between one line and another, and then you go out back to your home. And actually, that's kind of, in many ways, how a healthcare system works. A healthcare system, we've got thousands and millions of people who are using the system. They're coming in from kind of community care. They might be dealt with in community care, but they might need to come into the centre, into the hospital, and have kind of more specialised services. In London, we have the night underground and the day underground. In our healthcare systems, we have a night version and a day version. So although they're completely different, there are some parallels between the two ways of seeing the world. And interestingly, and if we didn't have a London Underground map, if you imagine going to London and trying to navigate your way around the underground system, you can't actually see it because it's all underground. You can only do it because you have a map of how it works. But interestingly, in our healthcare, we try to get patients and people to navigate around a complex healthcare system without understanding, without actually very often having this kind of overview of how it looks. And I just out of interest, I visited Sao Paulo probably about 10 years ago, actually. So I thought I'd pull out the Sao Paulo underground map. It's not quite as complicated as London's, but it's got a similar dynamic to it. It's got a whole series of different lines that intersect. So again, you've got your equivalent in Brazil. You've got your equivalent in other cities in Brazil as well. Okay, so if you hold that in your head, the London Underground map, Harry Beck worked out a very systematic way of translating something which was complex into a visualization that worked. In my work, I've used some of those kind of principles to kind of construct a methodology for seeing healthcare systems. So in a healthcare system, that this is the kind of the legend that drives my what I call patient ecosystem maps. In a healthcare system, you always have stages in a patient journey. It doesn't really matter what the patient is experiencing. It might be something which is resolved in an hour, might be something that's resolved over a week or several months. It might be a long-term chronic condition, but there'll always be stages in the patient journey. There'll always be stage 0, which is preventing the need for the pathway. Stage 1 is the trigger for the pathway. Stage 2 is signposting. Stage 3 is diagnosis. Stage 4 is treatment. Stage 5 is some point of discharge. When the patient goes into the system, they meet different people as they go through that journey. They interact with all sorts of different people, and the interactions take place in different places. They might take place in the home, the community, in what we call in the UK primary care, or in secondary care in a hospital environment. And the patient is the person who kind of connects and joins everything together. So if we think about those as a set of rules for mapping out healthcare, we can actually construct what I call a healthcare underground or metro or tube map. In London, we call the London Underground the tube map. And if we apply all of those principles of mapping, mapping stage 0, stage 1, stage 2, stage 3, stage 4, stage 5, we come up with this map that you can see in front of you here. So this is a map of, it's a very generic map. It's a map almost of any healthcare system of what it looks like from a patient's point of view. The patient starts on the left at home. They're in a stage of prevention. They have a trigger for a pathway, which is a blue circle. And then they have all sorts of different ways that they can enter the healthcare system. These green boxes here represent primary care or general practice, as we call it in the UK. They might dial an ambulance, which is 999 in the UK. They might go to a smaller hospital or a larger hospital. They might get signposted. All these little red circles represent different places where they can be treated, and ultimately they discharge from the system. So this is a kind of underground map, which kind of provides, if you gave this to a patient and explained it to them, it would allow them to actually navigate their way around the healthcare system in a way that perhaps they haven't done before. So this is a generic map. I've done this form of mapping in different healthcare systems in different places. Each one has a slightly different shape, has slightly different vocabulary. Some healthcare systems have lots of hospitals, some have fewer, and so on. But in principle, there is this kind of background to what the map looks like. Okay, so interestingly, when we think about healthcare, we always kind of think in the UK, we have the National Health Service, and everybody is always kind of either praising or complaining about the National Health Service. And they kind of think of it as being one massive, great big thing in England. But in the UK, we have NHS Scotland, NHS England, NHS Wales, and NHS Northern Ireland. They're all run according to a different system of governance. And each of these healthcare systems is made up of its own little ecosystem of healthcare delivery. It's got its own little tube map. So actually, healthcare is delivered through a whole series of little cobwebs. It's not one massive cobweb. It's lots of different systems. Okay, so in healthcare, we are always trying to kind of think through, in my particular area or my locality, what does this system look like? And if we can see the system, can we actually use that as a way of bringing people together collaboratively, using some of those approaches from design thinking, and get those people to think collaboratively and think about changing the system in a slightly different way. And that's really what lies at the heart of my work. I call it kind of patient ecosystem mapping, and it involves 4 steps. Step 1 is to define project aims and system scope. So I work with healthcare professionals who come to me with their system challenge, and I say to them, right, well, let's kind of put a boundary around this. What is it you're trying to do? So we define the project aims and system scope. We then work with the team and we build a map of the system, the as-is system. So we create this visualization. I use this particular mapping approach to create a representation of what the local system looks like. And that's all very interesting. It's great to have the map, but the map then creates a platform for a really good collaborative discussion. In healthcare, classic challenge is people don't collaborate enough. People don't talk to people in another kind of healthcare silo. And if we want to have the system change we need to kind of facilitate much broader and more collaborative discussion. And then when we've done that, we can then kind of come together systematically work out what are the challenges in the system and systematically work out what are some of the kind of improvements we can make. So step one, step two, step three, step four are the ways that we can use the patient ecosystem mapping approach. So I'm just going to talk you through those steps and illustrate them, and I'll just finish off with a couple of little examples of how this is being used in different scenarios. Okay, so step one is define project aims and system scope. So I've worked with this approach with a whole series of different, in the UK, NHS boards and trusts, NHS Grampian, NHS Lothian. They all represent different areas of Scotland, Northern Ireland. And I've worked with them on a variety of different challenges. They come to me and say, well, the challenge, Tom, is we need to improve access to urgent care, or we need to enhance the transition from pediatric to adult cancer services, or we need to reimagine outpatient services, or we need to rethink home care, or we need to redesign patient feedback, or we need to reduce variance in care, or we need to reduce medicines waste. These are all the kind of starting points for my mapping projects. So we always kind of think, right, well, that's the challenge you want to address. Let's put a boundary around it and let's try and kind of construct a map which will help you address your challenge. So we define the challenge and then we build a map. So I've shown you the kind of the patient ecosystem map based on this idea of a transport map. What we do is we run a whole series of online workshops. We try and bring in as many people who work across the system as possible. We try to make it incredibly time efficient. So what we do is we run online workshops using Miro. We bring along a version of the map, and then through a series of 4, 5, 6 online workshops, we might bring in 10 or 20 key stakeholders from across the system each. Each one contributes to the map and helps build an agreed representation of what the particular healthcare system looks like. So here I've got an image from one of my Miro boards. There's one of my maps there, and I've had a whole series of different people in an online conversation, and we've edited the map. And ultimately, if we go through this process, we construct a map which everybody's familiar with. They agree that's what the system looks like. And then we can use that as a platform for further discussion and debate about, what are the challenges in this system? What are the opportunities for improvement? And how do we then prioritize them? So to do this, we move from an online environment. I usually bring people together for a day or 2 days, and we take them through a system sprint. So again, this is kind of taking approaches from design thinking and getting people to kind of work collaboratively. We might have 50, 75 people at the system sprint. We might have staff, we might have patients as well. And we get them to kind of work through a whole series of different exercises. So I bring my map along and we get people to look at the map. Because we have a map, I can bring patients along to this workshop and they can tell us about their own patient journey through the map. So that's about like me telling you what my own personal journey was around the Sao Paulo Underground or the London Underground. What were the challenges? What was working well? What were the improvement opportunities from a patient's point of view? We can use some approaches from systems thinking. I quite often get people to think, well, what are actually some of the root causes of those challenges? So we use iceberg models to think about data challenges. What are the kind of, what's data telling us about shifting trends? What are the structures in the system that cause challenges? And most importantly, what are the mental models that influence the system? And then we spend some time using creative methods from design thinking to think about what are the future aims? What are the improvement briefs? What are some of the kind of improvements we've seen that other people are running in other systems? And we use what's called the 3 Horizons framework to kind of map out how we take this information and we can kind of take it forward as a kind of cohesive plan. Okay, and then we, after doing that, we take all of that information and we then kind of sort it, and it allows us to kind of think about improvements and innovations at different levels. Usually we have some improvements and innovations which can be made at a local but bottom-up level, where we get people in different parts of a system. We kind of empower them to make some changes. Sometimes changes can only be made across a system, at a regional level. Very often system improvements can only come by going to the next level up. So in Scotland, we have 14 regional health boards. And there are many improvements that can only be made at a Scottish level IT systems and so on. So we kind of usually triage our improvements into those three levels when we do these design and system sprints. So that's how the methodology works. Here's a kind of couple of examples of it in action. So I'm going to show you a couple of examples, you'll see some different maps. They all kind of look quite different, but they're all based on those principles that came out of the transport map. So this is a piece of work from Northern Ireland, from Belfast. And in this project, we wanted to rethink home care. So care at home is extremely interesting. If you don't have a good home care system in your healthcare system, you put huge pressure on your hospitals. You have more people coming to hospital than are needed, and it becomes incredibly difficult to discharge from your hospital. So it's a kind of really important area to get right. In my map here, we've got the hospital down in the bottom left-hand corner. It's discharging people into all of these different pathways of home care. And interestingly, this was the first time they'd ever mapped it out. So it was the first kind of time they had a visualization, and everybody working in home care found this an extremely useful thing to have in order to explain how their systems work to other people. And in this project, we took the map, we explored all of the challenges in the existing system. We explored 14 or 15 potential ways of improving it. This all came together into effectively a 24-month project. And as a result of doing this work, the team made not just one intervention into home care, but 6 or 7 interventions over a period of time. This ran from September 22 to January 25. The number of people waiting for care packages in the system went down from 800 to 180. So it had kind of quite a profound effect. And so it was about making a kind of system-wide change across the system, but doing it in a very collaborative way, bringing in voices from everybody who was involved across the system. This is another example. Again, it's another map. It looks kind of confusing, but this is a map of what we call urgent unscheduled care. So we've got patients coming in from the community. In the UK, these are the 5 different ways that they can enter the system. They can go and see their GP. They can go and see community services. We have a system in Scotland called NHS 24, which is a phone delivered service. And we have the Scottish Ambulance Service. Or patients can go directly to an emergency department, to a hospital, to get urgent care. And this is almost like a board game. You start off on the blue circles, and urgent unscheduled care, you have to receive your treatment within 24 hours, in theory. So you've got to go from a blue circle to a red box within 24 hours. That's the kind of aim of the board game. So this kind of visualization helps the team see the system as a whole and kind of come out with kind of system level changes that can be made right across the system. So in this project, I've had over 100 people involved in constructing the map, and we'll be running a 1-day sprint with 50 of them to come up with those kind of systemic changes to the system. Another project, this is quite specialized, quite specific. This is pediatric to adult cancer transitions. So this is for the big children's hospital in Edinburgh. Really complicated. If you are a cancer patient, if you start in pediatric cancer services, you might have to transition to adult as you become older. And the 2 services quite often are quite different. So we've been mapping out what the 2 services look like. And I've been working with the teams to think through what are the 5 or 6 things we can do in order to kind of improve how this system of care works. Another kind of complicated project was looking at clinical genetics in Scotland. In Scotland, that's delivered through 4 regional services. We created a map for each regional service, and that allowed the teams to look at what was the variance between the different services. So it kind of gave them a platform for the first time, they could kind of lay out on the table, this is the Western service, it works like this is the Northern, this is the Southern, this is the Eastern. What are the differences in those systems, and why are they different, and what can we learn from each other? So it became an incredibly useful way of sharing best practice across kind of 4 regional systems. And finally, this is my final example. This is slightly different. It's kind of not driven so much from the patient point of view, but this has been a really interesting project. It's with the Scottish Government. We're looking at can you visualize and map out the medicines journey in Scotland? So it's a very high level map. It's looking at medicines waste. So it's got the medicine supply chain here on the left-hand side. On the right-hand side, we've got patient journeys. So in Scotland, into its public health system, it buys 2.3 billion pounds worth of medicines a year. That's about 3 billion US dollars of medicines a year. Probably about 10 to 20% of that medicines is wasted. So where does it get wasted in its journey as it goes through the system, and what's the environmental impact? So we've been constructing this map. I've worked with about 100 people from across the system, and they now agree this is what the system looks like. We're now taking that into a series of workshops where we can look kind of systematically what are the kind of the portfolio of different interventions that are being made into the system to have an impact on those financial losses, but also the environmental impact of medicines as well. Okay, so that's a summary of the patient ecosystem mapping. Good. So that is the end of my talk. So I've kind of told you a little bit about myself. As I said at the very beginning, I'm not a healthcare professional, but I do work very, very closely with healthcare teams. My background is in design and innovation. I'm very much a kind of facilitator and a coach, and also a kind of trainer. I train up lots of people in these approaches. We kind of turn it into training packages and so on. My mission, if you like, is to bring design and systems thinking into healthcare. We bring design thinking into quality improvement, but also extremely interested in how can we bring some systems thinking approaches into the system. And that's where the patient ecosystem mapping comes from. So in my work, if you're interested in it, please do connect with me. There's my email, there's my website, and I'm also very active on LinkedIn. So do join me on LinkedIn. I will circulate to you 2 or 3 papers. So there's a paper that talks about bringing design into quality improvement. And I've also got a recently published paper about patient ecosystem mapping, which has more details about 1 or 2 of those examples that I've been sharing with you. So get in touch if you're interested in the patient ecosystem mapping approach. Hope you enjoy the rest of your Congress. It's been a real privilege and a pleasure having the opportunity to chat to you. And good luck with your systemic challenges in Brazil, because you'll have them like everybody else does in the world. So thank you.
What question can you ask to start thinking about applying this approach you present to us?
Okay, so rather than 2 questions, I have 2 challenges for you based on some of the things that I've been talking about in my presentation. So challenge number 1 is to make yourself a cup of coffee or a cup of tea or whatever it is you want to drink, and sit down and find yourself 30 minutes and sit down with an A4 piece of paper and a pen, or an A3 piece of paper, and can you actually draw out the ecosystem that you work in? So put yourself at the middle and think about it. Wherever you are in the healthcare system, can you draw out all of the boxes that are sort of upstream from you and downstream from you? So where do the patients and the things and everything come from that interact with you? And after they've interacted with you, where do they all go to? And you will kind of have familiarity with the things which are close, but I'm asking you to go all the way back on the kind of upstream side to people in their homes, and all the way forward on the downstream side to people being back in their homes. So it doesn't really matter how you visualize it, but I want to put you in the middle and I want you to kind of draw it out at a really, really high level view and see whether you can, by doing that, do you kind of learn something from it that you didn't realize? It might be something you might perhaps have this map already, but that's your kind of challenge number 1, which is kind of the challenge I always kind of set when I'm kind of working with people on ecosystem mapping. The next challenge is kind of slightly more abstract. It's to look down on that map once you've constructed it, and then imagine that you are Google Maps. So I'm sure you've probably played around with Google Maps. In Google Maps, I use Google Maps all the time to navigate my way around both my own locality, and when I go to somewhere, if I'm on holiday, I use Google Maps if I've got a hire car to drive around. So in Google Maps, you know that you can zoom in and zoom out. So in Google Maps, You can zoom in and you can, you can zoom out. You can see an entire neighborhood, or you can see an area of a city, or you can see the whole city, or you can zoom out and you can see where the city sits in the country. And then you can zoom back in again. You can see the city, you can see the region where the neighborhood is, you can see the neighborhood, you can see the street. You can zoom down into the street, you can see somebody's house, you can almost see into their back garden, and then you can zoom it out again. So in Google Maps, we zoom in and out. So I want you to look down at your sheet of paper and think, can I zoom in and out of it? And do I kind of see it in a slightly different way when I zoom in and out? And then the final it's kind of challenge part part two, if you like, is then to think about that kind of system you're looking at. And in Google Maps, we on the right hand side in Google Maps, we always have that a little yellow person that we can drag into the map, and we get Street View. And when we see Street View, we don't see the system in a kind of diagram form. We see it as you actually experience it. So we can see shop fronts and we can see the traffic in the street. So your street view is you need to kind of draw a little yellow figure on the left-hand side or right-hand side of your map. That is actually your patient. Your patient doesn't see the system. They just experience the healthcare ecosystem as street view. So drag your little yellow figure into your map and then think about, well, what is it? How does it actually appear from a patient point of view? Can actually a patient make any kind of sense whatsoever of my ecosystem of healthcare? So they're not questions, but these are just kind of, in a sense, mental challenges that perhaps kind of make you think about your healthcare system in a slightly different way. Particularly the one about seeing the patient perspective in your healthcare system, dragging the little yellow person in. It will make you realize why your patients don't know what's going on. They can't navigate their way around the hospital. The signage doesn't work. They can't park their car properly. The phone line doesn't work properly. They don't understand what's in the letter that they've been sent. That's the kind of street view perspective on a healthcare system. So hopefully they kind of that those two little challenges perhaps get you to think about, where you are in the system, and might make you reimagine what are the challenges and what are some of the potential improvements and innovation. It's a kind of practical approach to kind of thinking in a systems type way. So good luck with your challenges. I hope they work for you, and share your insights with each other as you kind of generate them. But thank you very much again for having the opportunity to talk to you all. Thank you.
Thank you, Tom Innes, for your presentation. Agradecemos ao professor Tom Innes por compartilhar sua experiência e visão sobre como o design colaborativo e o pensamento sistêmico podem promover transformações reais no setor de saúde. Foi um verdadeiro convite à reflexão sobre o papel da inovação e da colaboração na construção de soluções sustentáveis para o futuro da saúde.